Now, you're all very welcome back again. And now it's time for plenary session C, Digital Health Opportunities for Public Health, How Far from Reality? And just to give you some context for this panel session, digital technologies have, of course, huge potential to be applied to public health to improve efficiency, use of data, sharing knowledge and information. But how have technologies been used during the pandemic, and how can we do more to make use of digital technologies to improve public health? And how can all of this be done safely? Well, these are just some of the questions that will be explored during this session. It's going to be chaired by two members of the ESCAIDE Scientific Committee. They are Vicky Lefevre, the Head of Unit for Public Health Functions at the ECDC, and Petronille Bogaert, the Project Researcher and Head of Unit at the EU Health Information Systems at Sciensano in Belgium. And our two chairs will introduce their panelists. So you're all very, very welcome. And Vicky and Petronille, I'll hand over to you. I think, Vicky, you're going to start the proceedings.
Yes, thank you very much, Karen. Welcome to all of you in the audience to this session on digital public health. My name is Vicky Lefevre, and together with Petronille, I will be the moderator for the session in the next hour and a half. As you are aware, the pandemic has accelerated the use of digital technologies for public health. In the area of real-time surveillance, response to the pandemic. So this session will focus on digital opportunities for public health, but will also highlight some of the drawbacks and challenges when using these technologies. So we will also look a bit ahead. So what changes or how could digital technologies change the future landscape of public health? I will now pass the floor to Petronille to introduce herself and the format of our session.
Thank you so much, Vicky. So also a warm welcome from my side. And so indeed, in this session, we will hear a story from 4 speakers that have pioneered digital health solutions and covered new ground in public health services. So they will present their work in a TED Talk format, which we're very excited about. The themes and questions that will be addressed during the sessions are whether the expected benefits of digital health technologies for public health and infectious disease epidemiology, what are the main challenges and concerns related to the adoption of digital health technologies at scale for public health, and what will be the impact of digital health on public health in the future, and how do we move towards using digital health intervention as part of public health systems. So Vicky, back to you for welcoming our first speakers.
Thank you very much. So our first speaker will be Professor Ran Balicer from Israel. So he is the founding director of the Clalit Research Institute, where he is also the Chief Innovation Officer. He was appointed chair of Israel's National Experts Panel on COVID-19 and serves as a senior advisor to the Israeli government. He will tell a story about how Israel has leveraged digital solutions for better public health decision-making during the COVID-19 pandemic, and also what lessons can be learned for the future. Then our last speaker, Dipak Kalra. Professor Kalra is the president of the European Institute for Innovation through Health Data. He led multiple EU projects and developed ISO standards in EHR, interoperability, data protection, business models, and the reuse of electronic health records for research. He will outline how health data can drive innovation for public health with an emphasis on public trust. Over to you, Petronille, for the next 2 speakers' introduction.
Thank you so much. It's my real pleasure to welcome Peggy Knudsen from Norway and Stefan Buttigieg from Malta. Peggy is the Deputy Director for Digitalization and IT, and she's Acting Director for the Infectious Disease and Environmental Health Division at the National Public Health Institute in Norway. She's very much involved in the COVID-19 response and will even have to leave us just a little bit early, but she will give us a very interesting presentation on the work on the 2 COVID-19 apps in Norway that she has developed, and she will cover this topic, including issues related to data protection, professional needs, and legal restrictions. And then we have the pleasure to have Stefan Buttigieg from Malta. So Dr. Buttigieg is a specialist in public health medicine in public health at the Ministry for Health in Malta. And he's also co-founder for the Digital Health Malta and vice president of the UFA Digital Health section. So he has an avid interest in clinical informatics, social media, and digital health. You might have already seen him on Twitter or other social media platforms. And he's currently lecturing at the University of Malta, the Faculty of Health Science, on the topics of digital health and social media and healthcare. And he has developed a Maltese contact tracing app, and Dr. Buttigieg is on a mission to enable digital health for all and ensuring that no one is left behind. Back to you, Vicky.
Okay, so this will be an interactive session. I think you're already used to it. We have a chat where you can post your questions that you would like us to ask to the speakers. So if there's time left, we will ask questions immediately after the presentation. If not, we keep them for the panel discussions. So please, Professor Balicer, the floor is yours for the first presentation.
Thank you kindly for the opportunity to be speaking with you today. In this short presentation, I would try to take a view of what data-driven pandemic management looks like from the Israeli lens. So let's start with no further ado. And perhaps we can move the slides. Or we don't.
Yes, we can.
Okay, let me see if I can. It will. Let's see.
It's always a pleasure of having things live, technology being on our side. Just bear with us for a few minutes, and I'm sure we'll get it up and running.
Sure.
I see them moving from our side.
You do? So
Yes.
am I on the next slide right now for you?
Yes, you are.
For me, yes.
Okay,
go ahead.
Good enough. I will go ahead then. Thank you kindly. So, you know, whenever an event of the magnitude of a pandemic actually takes place, the first sensation one has when one's in office of taking charge is a sense of fog of war. You not only do not know what the future is holding for you, you actually are not sure what is happening right now. So there's a lack of situational awareness in many instances. You need to make decisions with a lot of uncertainty. And in those instances, when the challenges are great, you usually revert to what you are used to do and what the system that you work in is usually does in the day-to-day. And for us in Israel, and specifically at Clalit Health Services, which is the organization I work for, which serves over half of the Israeli population, usually from cradle to grave, and is holding an abundance of digital data for over 2 decades. The way we conduct our daily business of providing care to our population is in an approach which we call predictive proactive care. And what this stands for is a form of population health in which we try to identify patients in the point in time in which they look well and they feel well, but there's something about their medical records, something about their data of their tests and their comorbidities and their behavior that hints to us that something bad is about to happen to them. And if, and only if, we will intervene early enough, we will be able to prevent that potential future from happening. But as I said, the person looks well and feels well. So we need to use tools usually from the realm of artificial intelligence and machine learning, in order to identify which ones of the patients are going to deteriorate. And this example that we see in front of us, it is in the case of renal failure. And we can identify them sometimes 5 years before they actually have the first sign that they actually might need dialysis or renal transplantation. And when we come early enough, the treatment is cheaper, it's easier, and it's more comfortable for the patients. So this population health approach basically takes us away from the patient level reactive therapeutics into a domain of population health, of predictive, proactive, and preventive care of non-communicable diseases. So this is our general approach. We do this for a dozen different diseases on a daily basis for all the population we care for through our general practitioners, which are used to receiving those highlights from the machine learning algorithms that run in the background. And so when the pandemic hit, what we did, first thing that we did was the same thing for COVID-19. And very early, we have created a predictive model that would identify which ones of our population are going to be deteriorating to severe COVID-19. It was very early, it was March 2020. But even at that point, we created the first predictive model for who's going to deteriorate. We stratified our population into risk levels, and those that were at the highest risk, a GP called each and every one of them. 200,000 patients were personally called by their GP, requesting them to be careful and not to go into crowded places where they can be exposed. And later on, this same model was used actually in the last month and a half to find those people at the highest risk when they got infected and to offer them the treatment with Regenkov, with the antibodies that are able to provide prevention of severe illness if they're given early enough within the first days after infection. So this kind of an approach is one example of how one can use data into providing the combination between a general practice and public health on a usual basis. Now, so what I've shown you now was not only to tell those people not to go into crowded places, but also to tell them that if they require care, they should receive that care through telecare and remote monitoring, and not through physical attendance at the clinic level. So that was very helpful. Now, the third example I wanted to give into how one can use the data is in terms of realizing quickly what works and what does not. And since Israel was the first country in the world to provide mass vaccination, and we vaccinated nearly 60% of our population by the end of March 2021, we were the first to be requiring the understanding of whether or not these vaccines work. And so we started, a whole set of publications, and the first one was on February in the New England Journal of Medicine, showing for the first time that the vaccines actually work with 94% vaccine effectiveness. And then a set of other publications, this one's from Nature regarding the adolescents and or in pregnancy, showing the effect of the vaccines. We also tried to understand the safety and the profile of these vaccines, and we were able to provide the first large-scale evidence of 4 different adverse events for the vaccines, including myocarditis, but also appendicitis and shingles and lymphadenopathy. And we could actually show that, for instance, myocarditis is more prevalent among those who contract COVID-19 as a side effect of the disease than those who actually take the vaccine as a side effect of the vaccine. So I think all of these insights are pretty important in making informed decision in public health. And this is another publication from the same journal that on myocarditis, on the actual follow-up on these patients. This last one, I think, is requires a little more discussion, because right now we have just now at the end of wave 4 of the post-vaccine Delta wave that we've had, and we've seen a huge ascent of cases, 8 consecutive weeks of exponential growth in cases in Israel. And only later on we understood why that happened. First of all, because we eased all our restrictions in May when we thought we were out of the woods. Second is because of Delta. We all know by now that Delta is exceedingly effective. But finally, we learned the hard way that vaccines have waning. And the waning immunity is very substantial. And by 6 months, you are no longer protected as you were in the months after the first 2 doses. And so we have decided in Israel to start a booster campaign. And the booster campaign was started by age groups. So the elderly first and the younger later. and we've by now basically gave over 2/3 of our those people vaccinated with 2 doses, and actually 80% of those who are entitled for the booster dose already received their booster dose by now. But since it was gradual by age, we could actually assess also some of the impacts of the booster. And what we saw, and this is from the Lancet piece from a month ago, we could show, first of all, that the boosters provide 93% vaccine effectiveness against hospitalizations, 92% vaccine effectiveness against severe disease, and 90% reduction in deaths. 81% protection against death. And what you can see here in this graph shows that the graduality of the decline of cases happened in parallel to the introduction of the booster dose. I will not go too much into it. I think this is more the idea that what I'm trying to make here. My final slide actually aims to talk about what are the lessons learned. And I've been fortunate to take part in the Lancet and Financial Times Commission that has been convening on the last 2 years, trying to define how one should govern health futures using digital health in the future, especially for the health of young people. And 3 of the most important take-home messages that I will drive here from that report that were actually shown in my examples. One is that the digital transformation and the digitization of health services is no longer nice to have. It's a determinant of health, and connectivity and the infrastructure, enabling infrastructure, is a human right, basically, because it
Sorry for this short interruption. So we're very happy now to have our next speaker. Again, Peggy will be talking about digital contact tracing, speed, trust, and benefits. Over to you again, Peggy.
Thank you, and thank you for the opportunity to tell a short version of the story of the roller coaster journey of launching a digital contact tracing app in Norway, Smittestop. I will start by taking you back to the grave moment of the introduction of lockdown in Norway in March 2020. No one in Norway expected, I think, such large or intrusive measures as those introduced at the press conference by the Prime Minister this day. However, by this day, the idea of a digital contact tracing app had been worked with for a few days, exploring the possibility and keeping an open mind as to whether this would be possible or not. With the lockdown, a great sense of urgency came to explore and come up with measures and solutions that would contribute to end the lockdown and open up the society again. So, although we at first thought that the idea of developing an app in such short time frame was going to end fairly quickly with a report stating that it couldn't be done, the team grew, collaborators eagerly joined, we made a plan, and we actually developed not only an app, but also all the necessary surrounding infrastructure and system integrations. We had a record-breaking timeline and milestones that were beyond all best practice and project management plans. And we worked under the extreme pressure from an anxious society in lockdown and decision makers, politicians that really wanted to open up the society again. So we built a system not only for contact tracing, but also for using the data collected for contact tracing to give us early signs for where and when the potential for spreading events were high. When opening up the society again, we knew that people would meet and make contacts again, and we wanted to learn more using anonymized data from this system on where hotspots for spreading actually occurred by counting number of close contacts within areas such as parks or public transport. On April 14th, 4 weeks after the first press conference with the lockdown, the Prime Minister again held a press conference and launched Smittestop. Preparing for a silent release, we really stressed that our digital tracing app only should be launched as a pilot for testing. But in practice, we ended up with the early release of an unfinished app in April, based on non-optimal technology, collecting large amounts of data and using a lot of the mobile's battery while running. We were live and in production while still in a pilot phase at the same time. And at the very same time, the number of new infections started to decline in Norway, resulting in too few cases that could be included in the test and pilot phase. The declining in infection and the end of the first wave was, of course, very good news for Norway. but we actually had quite detailed and thorough plans for doing parallel contact tracing in real life, comparing manual contact tracing with the digital tracing. But the spring and summer came, and with it probably also a positive seasonal effect on the epidemic in Norway. So during the spring and early summer days, the high expectations of the app were not met or needed. We were not able to demonstrate actual results and usefulness in time. Data protection was highly challenged, leading to trust issues, particularly within tech groups, due to the technological choices we made in March. To get sufficient effect on the tracing, in March, we had to use a combination of GPS data and Bluetooth, and this was highly debated. We also saw during this time that all the municipalities in Norway were able to successfully establish and staff up manual contact tracing teams that did a really good job. And this has been kept up throughout all the subsequent phases and waves, the manual contact tracing. So after we had developed and launched our early version of the app, Apple and Google had joined forces and presented in May how they would make new technology available within the summer. So by mid-June, the first version of SmittStop was suspended. During the summer of 2020, enjoying a near to normal life again in Norway, you can see that the number of test positives was really, really low in Norway. We paid close attention to the development of Apple and Google-based contact tracing apps in EU countries. And when August came and the rise in the epidemic again happened, we decided to start again. This time, we took care and more time, 3 to 4 months. This is also a short time period for developing a new system, but it's longer than 4 weeks. To do all the steps to ensure that the best technology available was used, we had to use the Apple and Google technology, and we successfully developed and released a new version of SmittStop in December. With no debates or controversies, the data privacy was so high that even the most critical voices from the privacy discussions concerning the first version promoted using the new app. But was it a success? Well, we know that this app that we have running now is working well. We have tested and we have simulated, and the app and solution performs well. And we know that the level of data protection is extremely high. Actually, the data protection is so high that the real effect and benefit from using the app in the society will never be possible to measure directly. We only know how many users that download the app and how many users that chooses to alert others through the app. We do not know how many users that actually receive an alert. We can see that we have fairly low uptake in Norway, below 20%, and under 5% of test positive use uses the SmittStop to alert contacts. But again, the app works. Contacts have been alerted, probably resulting in breaking chains of infection. So, was it worth it? Well, that remains to be seen, and it is a question that can be answered on many levels. I do not think that the digital tracing apps have been the one key element or the crucial solution to the pandemic at any time, nor were they intended to do so. We wanted to use digital tracing as a supplement to the manual contact tracing. But I do think that they are very important and successful digital solutions based on two things. First, I believe that especially in times of real crisis of unknown proportions, innovations and boldness should be encouraged when tackling the crisis. Secondly, in my opinion, we have never seen such a willingness to collaborate, contribute, harmonize, share ideas, plans and experiences, and work together across sectors and across borders in such a scale within digital health. My final and perhaps most important point, trust is essential. Openness and transparency is necessary to build trust, especially when things are uncertain or doesn't quite work out as planned. all the debate and discussions on how to use health data, personal data, data privacy issues, and data protection measures is most welcome and needed when we move forward and implement more digital health technology in our public health interventions, as we will do. Thanks.
Thank you so much, again, Peggy, for sharing really, I think, this honest view and the experiences that you've had with these applications. I don't see any questions from the audience, but don't hesitate if you still have one, just pop it in there. But so I understand that the process was quite different when you first launched it and then launched it a second time. But it seems like when you launch it the first time, you lose a bit of the momentum when it's launched the second time, and then the trust issue comes in. So my question to you would be like, how do you think the process could have been improved if you would have, another opportunity at taking that up in the future?
Well, currently the most critical voices actually raise one issue, and that's you can never launch an app twice. You only have one time point, so you only have one chance. Well, it's easy to say that in hindsight, but I think what is really necessary is to keep informing, to keep communicating, and to keep showing why this is useful for the user. So that's a key element, I think, in providing. And I actually think that manual contact tracing in Norway, especially, or perhaps all over the world, when that is effective, that's a disincentive for a digital contact tracing app.
Yeah, and I think this fits in quite nicely also with one of the questions from the audience is, what is the reason for the low uptake of the SmitStop app in your opinion?
Well, I think it's many reasons for the low uptake. I think it depends on where in the phase we are. I think we have received notes that we don't see it necessary because we don't have contact with people. So that was quite often a response, or we never attend large concerts, or they are not allowed in this in time period. So I think now perhaps is the best situation for such an app when we actually have a really open society, and we do have a lot of contacts. So yeah, we'll see.
So will there be a relaunch at some point, or a re-promotion, given that the situation is better for the usage of the app?
Yeah, we will try to reinforce the communication and the information campaigns from now and further on. Yes, we will.
Okay, great. Thank you so much for your time. We know it's very busy at the moment. It was a real pleasure having you here, and we look forward to seeing you in other opportunities. Okay, so let me move on to our next speaker. And of course, please continue submitting your questions in the chat. We will now be moving to Stefan Buttigieg. He will be talking about Malta's digital COVID-19 response, and he will give his reflection on that. So Stefan, the floor is yours.
Hi, everyone. So thank you for this invitation today. And I'd like to share my story. I'm aware of many hats. So that's why that very large hat in the top left corner. But one of my biggest roles, especially in the past 22 months, was being involved in the Ministry for Health as the deputy lead for the data management team in the COVID-19 response. But I'm also I'm a co-founder of Digital Health Malta, which is a non-governmental organization. And I work also on a couple of other NGOs. So what does this give me? It gives me a unique perspective on the COVID-19 pandemic, to look at it not as simply just from the government point of view, but also to look at it also from a non-governmental point of view and see what's happening as well on the ground over there. I would like to mention 4 big wins that we've had through the COVID-19 pandemic, and that is mobile apps, definitely. Now we have really scaled up our knowledge with setting up mobile apps within different ministries for health. We have now a deeper of an understanding of data science and data flows. Look at all those different open data sets that we see out there. Just even an understanding and awareness is already a big win. We're also seeing digitalization, communications and operational changes. So people changed the way they work. We've seen around the world how they were still receiving faxes for COVID-19 positive tests. But that, I hope, is a thing of the past anymore. So not really their part of it. And last but not least, an immense scale up in human resources and digital infrastructure. So we've seen like top class solutions that we've seen in Israel, but now we're also seeing that other EU states, which possibly might have lagged behind, now they're catching up extremely quickly. That is definitely something which is scaling up for all EU member states. But I just want to give you an idea of what we've done throughout the pandemic from different perspectives. In primary healthcare, there was the first ever telemedicine center open in Malta, officially rostered, fully equipped 24/7, and in less than 2 years, now they've reached more than 200,000 consultations. Mind-boggling when you think about a couple of hundreds per month previously. As mentioned before, I was deeply involved in the COVID alert contact tracing app in Malta, and this is the landing page. And what was interesting about this landing page is that we opted to use WordPress, for example, here, WordPress and the protected WordPress version, to be able to get as many downloads as possible, to give them a clear call to action. And that resulted in, up to June, it resulted to more than 100,000 unique downloads. Of course, the uptake is not as high as it was before, but definitely this was something incredibly unique. It has definitely become one of the most popular apps in Malta in relation to health, and the ratings were quite high. So this is all positive. The work that was put into it to make sure that it's compliant with data protection regulations and principles made it a success in that sense. So we definitely learned a lot from this, and as a result of that, then we had other initiatives, such as the registration for the COVID-19 vaccination registration. That was like fantastic work done by my colleagues at Mater Dei Hospital. And just to mention as well that this app was a collaboration not just with the Ministry for Health, but was a collaboration also with the Malta Digital Innovation Authority that worked on the auditing aspect, and also, very importantly, with the Malta Information Technology Agency. It was also another big win, where when everyone works together in such a strong way, you can do miracles, you can move mountains. Also, there was a lot of work done on the vaccine certificate. So this was a clear call to action, one-stop shop to generate your vaccine certificate. And also there was a specific website as well to create your own test and recovery certificate. In Malta, we have fully embraced the Microsoft Power Platform to do our work in relation to COVID. And we used Power Apps, Power Automate, Power BI, and even strongly embraced Dynamics 365. And with that in mind, we have enabled more than 100,000 requests to order a swab request. That was done through covidtest.gov.mt. And you can see a bit of a hint of how the backend of the Dynamics CRM. What was successful about this? This looked familiar to many of our collaborators. And because it looked familiar, then it was easier to uptake. And because it was easier to uptake, then we were able to get the full benefit of it. But apart from that, we've also worked on travel authorization. So we had a system, a traffic light system, but we also had red and dark red. And we actually used this travel authorization to authorize people traveling to Malta in specific circumstances. This was also before an email process, and then it converted to a more client-centric approach through Dynamics. That is also another hint at how it looks at the backend. And even Power BI reports built on top of this data, as seen over here. With that in mind also, though, we've also looked at collaborating on a European level, and we actually worked with the EU Health Gateways project on the EU passenger locator form. In fact, Malta is one of the 3 countries there who actually actively embraced the EU digital passenger locator form. A lot of information we can get from there to tackle different cases. And something which was a very big win as well is that we have fully embraced open data. This was critical. I've seen fantastic work done by many different EU countries. We are trying our best here, especially with a lean team that we have here in Malta. And we've also seen something extremely interesting where we saw the scaling up of social media presence of our Ministry for Health actually to more than 100,000 followers and also providing a credible source of information. But I'd like to conclude pretty soon, and I also wanted to mention how we use Power BI as well to try and get also a real-time analysis of vaccine certificate recognition to try and tackle. And it's very easy to see how also recognition of vaccine certificates also showed a bit of vaccine inequity. Something very interesting here. And something also that we've developed and worked extremely hard at was the deployment of verifier devices at point of entry. So we had specific devices to scan vaccine certificates on entry. And through these devices, we were able to expand our range of certificates. But I wanted to show you this very last important slide. And this slide basically covers all our biggest learning points from the pandemic. On the left-hand side, we have COVID, which was a chatbot that we had to kick off with because it was very useful. But then we had to reduce and eventually had to phase it out. The main challenges were human resources. So that is something that we definitely learned. Risk assessment through COVID-19 check. It had a very important role at a certain point of time, but then we saw that we could synergize and we could consolidate our operations, and then we decided to phase it out. It doesn't mean that we didn't learn, it wasn't useful or it was a failure. No, actually we learned from it and became even better. And we even consolidated further our Dynamics platform. Go Data, it's still being used, but we realized that it had a strong role as a case registry, so we enabled that. And my role at Digital Health Malta as well, we worked on Wenliang, which was also another chatbot, and we also worked on Health Hive, which was a telemedicine platform. But once we saw the success of the main telemedicine platform, we worked and we consolidated and shifted our efforts to other things. But to conclude, biggest learning points of the COVID-19 pandemic, especially when it comes to the digital approach. Scaling up of human resources and behavior change, incredibly important. The strong role of data management, operational workflow and business continuity, putting business processes up and front, extremely important. Sustainability and looking towards the future, not just thinking about the now, but also thinking about the future and thinking about internalizing the process. And multidisciplinary collaboration, extremely critical, which results in dedicated and agile project management teams. Very important for us to achieve the success that we need for public health and infectious disease epidemiology. Thank you.
All right, thank you so much, Stefan. And I think it was really interesting to see this broad scope and to see how actually digital health is really slowly taking an important role, and not just in one specific area, but in all these different areas. And in the preparation for this meeting, I also really enjoyed when you said that digital health is already here. It's already now. And I think you really showed that in your presentation. So thank you so much for sharing that. I have 2 questions in the chat, which I will take because I think they're very interesting. And I think it links in a little bit also with again, Peggy, her presentation. We have to be more and more conscious of privacy constraints and GDPR, of course, because trust is really important, and you actually named it. One of the main reason why the app was so popular, it's because it respected GDPR. But that also means that it's really difficult to assess the effectiveness and the impact of these different apps. So one of the questions from the audience is, given these limitations, how are you then able to further, improve these different apps, and how are you able to identify issues and actually make best use of it given these limitations?
So voluntarily, we asked people, when people were calling the helpline, which was the most popular, so to say, source of information, we voluntarily asked them, were you notified by the COVID Alert Malta app? And that was a voluntary, and if they could have opted not to answer the question. So that was an important source of information that we could able to get some basic information with the user's consent, asking them whether they were notified by the COVID Alert Malta app. So they could have said yes, no, or they could have opted not to answer as well. We kept the options open there. And because of that, then we were able to get a very basic idea of what's happening and what's not happening. But then again, as Gunn said before, we weren't able to kind of see the full impact of how many people were notified. And so there is this balance that needs to be achieved here. And I think that's how we can be a success, by trying to be also a bit creative as well at times.
Just for information, what was the coverage? How many percentage of the
population?
Okay,
so we're looking, in our case, it was 21.2% of the above the 13 years of age. So we have to calculate, because above 13 years is usually the time where people can actually download an app, and using the population demographics, then we're able to kind of determine that was 21.2% at its highest point.
Okay, I will go to another question which came in from the audience. Is how do you deal with continuous funding for any updates after development or for the future?
I think it's continuous communication. At the end, also kind of realizing where you're going to prioritize. So in our case, for example, we are prioritizing more our efforts now on customer relationship management systems, because we've been successful, they are in demand, and now we can continue building on them. So for example, in Dynamics, for example, you can use a chatbot feature. So what we've learned from the first chatbot, we can then transpose to the new experience, because we've learned so much from there. So even though we might not have a chatbot right now, we can actually learn from that first experience and actually implement an even better chatbot. So that is something that we're learning and constantly growing there. And that's something that I think that will also enable. So being ready to consolidate, and also being ready to say goodbye to your babies, so to say. So if you start a project and it's your baby, you say, okay, I have to let you go. I'm sorry. I need to move on to the next thing. So I think you need to be ready for that, because if you don't do that, then it's extremely difficult.
Yeah, thank you so much, Stefan. Yeah, indeed, it's all about change, and we've experienced a lot of change in COVID-19, and so we need to be open, as Peggy was saying, to innovation and things coming up in the future as well. Thank you so much, Stefan. I will now give the floor back to Vicky for our final speaker. Thank you.
Thank you, Petronille. Because Peggy needs to leave at 5 and we have a bit of time, maybe a question for the both of you, Stefan and Gunn. I mean, you've said both, it's already here, and it's true, it's already here, but is it here to stay? What will happen after COVID with the contact tracing apps, with the vaccine certificates, with the green passes, with the recovery certificates, with the EPLFs? Are they here to stay, or will they disappear as soon as quickly as they have been introduced? What's your opinion?
Well, that's good questions. I think that we really need to evaluate and gather information across all the countries that have these experiences. But I think they will disappear. They might be kept in a low functional hidden way to be awakened at a later time point or developed into new. But I think it's a really good question, and I think we barely have started to think about this, what we will do with this, because they have to be kept alive as well, technologically speaking. So it's a bit difficult, but I really hope that we will keep learning, and that we still will dare to try and do implement new tools in the future.
Thank you. Stefan, what's your opinion?
So if I may answer on that, if, for example, specifically the COVID alert app, we might actually have to, at the right time, we actually have to unpublish the app, because the privacy policy states so, that when the app is not needed anymore, we have to unpublish actually. So that is decided by our superintendent, who says, all right, now is not the time for the app anymore. But the lessons learned, those are going to stay with us for a very long time. And I can see a similar app, or maybe a reinvention of the same app, being used to monitor respiratory illnesses, not specifically COVID, but even other respiratory illness. And even just having a look at Germany, you see the Corona donation app, the data donation app, it could be transformed into something which is on a societal level, donating your data, and then not the app itself, but the digital communication campaigns, those should be the ones which are fluctuating and becoming stronger at specific periods of time. So those, I think, will have a big role there.
Thank you very much to the both of you. Then we go to our next speaker, which is Dipak Kalra. And you said there, Stefan, people want to donate their data or not. And I think this nicely brings us to your intervention, Dipak, because population trust as a key success factor for digital health is something that you will take up in your presentation. So please go ahead.
Thank you. All of these things you have to click at the same time. So thank you very much for inviting me to speak.
Digital health.
Yes, if I'm lucky, you're hearing me, you're seeing me, and you're seeing my slides all at once, which is wonderful. So I'm Dipak Kalra, and I'm delighted to be joining you. I'm going to step back a little bit from COVID and speak more broadly about our need to make better use of health data, and also to bring patients and citizens more squarely into that ecosystem. And if I may, I'd like to start just in a sense with waking up the audience. I feel you've probably all been really attending. The chat suggests it, but we've got a couple of questions for you. And there are two questions that I'd like you to answer in a poll. The first one is, how important will citizen-generated data, you've just heard about citizen-generated data from three great speakers, how important will this be to public health decision-making 5 years from now? Don't think of COVID, think of anything citizens might generate for us. And secondly, how well do you think citizens trust public health agencies with their data? In each case, I'd like you to score these between 1 and 5. I think the poll will magically come in front of you. I may not see it, but I hope you will see it. And basically, if you don't think citizen-generated data is particularly important, score it 1. If you think it's going to be of breathtaking value, give it 5. Similarly, if you think citizens are not really very keen to trust you or trust public health agencies, score 1. If you think they are very confident in trusting you, score 5. So I'm going to ask you to access the poll and press your buttons and click and do all those magic things. I'm not going to wait for your answers. We're going to give you a couple of minutes, and I'm going to carry on speaking. And so we'll just move a little bit into the presentation, and then we'll pause and see whether you've woken up or you're all still snoring loudly and not listening to me at all. So first of all, we know from a lot of work, and these are just little examples, that mobile health technologies given to patients to use in health situations is effective. And as one example, a non-infective example, telemonitoring of patients with heart failure has been shown to improve cardiac function, reduce heart failure severity, improve well-being, quality of life, and reduce hospitalizations. Those are all pretty hard outcomes coming from giving technologies to people to participate as collaborators in their own long-term care. The second bullet on the left is so simple compared to 3 presentations you've heard. I'm going to ignore it and let you instead remember the 3 presentations you've just heard. But on the right, if you leverage quite a lot of the sophistication that is in a humble mobile phone with a little sensor or 2, you can use the stuff in a patient's pocket to help with infectious disease diagnosis. So I just want you to realize that the opportunities are huge and exploding. They're even bigger than that, because in fact, as we think about the data around a patient, there is a huge amount of data already collected in healthcare, but also available in non-health situations. And some of you will be already connected with things like environment data, pollution data, transport data, health relevant, health impacting data. But don't forget, even things like social networks are a fantastic source of information about individuals if we're permitted to do it. So it's an exploding landscape around the patient, and we all underestimate how we could make better use of data. And I'd like to wake you up a little bit to that opportunity. If we think about the individual near to the patient, there are quite a number of ways in which data can already and will in future more assist with patient care. Things like health status monitoring, continuity of care, care pathway tracking, you're familiar with those. We do them well or badly in different countries, in different health systems, due to the maturity of the technology, but there are opportunities we know about. But real-time feedback and guidance to patients and clinicians, effectively decision support, and in the future AI that really is person-centric and is giving the clinician and the patient real-time information to help them. Then we have the population level, and this may be closer to you as an audience, where we start to look at quality and safety of care, care pathway optimization, medical devices and algorithms, pharmacovigilance, public health surveillance, and public health strategy, 2 things we've spoken about already in this session. And then at an even bigger data scale, things like medical devices, algorithms and AI again, drug development, developing stratified medicine. There are many ways in which we could use health data. And although in this audience you represent a particular slice of this opportunity space, my premise is that actually this is not about slicing anymore. This is about us collectively embracing it all. But I would like to know, dear audience, are you with me in this, or are you in a skeptical state? And I wonder if I could ask, I'm not sure how we can see the poll. I'm going to have to ask the technical wizards. How do we now see what your votes are? Do you have a clever way of doing that? Gosh, well, actually, I see a really tiny postage stamp. I would need a magnifying glass on my computer to see.
Yes,
Could
if
one
you
of
would
you
like
go
to,
in and see it? Could one of
if
you
you would
tell
like
me?
to, I can tell you what I'm seeing. So,
yes,
score
please do.
Score 1 is 9%. Score 4 is 11%. Score 2 is 34%, and score 3 is 41%. And I forgot score 5, which is the lowest, 5%.
Okay, so
how
many scored 1? This is about how valuable citizen-generated data will be. Could you remind me what the percentage was for only scoring 1?
Okay, so the question here was how well do you think citizens trust public health agencies
the
with
trust
their
question.
data?
Okay,
so this was the trust question. Yes. So the highest score was score 3, which is 42%. Then score 2, which is 33. Score 1, which is 11. Score 4, also 11. And score 5,
So
only
what
5%.
So effectively what we're seeing is that our audience population is either saying, you know, we think citizens live in the middle of this, or they live in the less trustworthy end of the spectrum. So I'm afraid to say our audience doesn't have really a huge amount of confidence in the trust our population has on giving public health agencies access to data. So I'm not judging that. I'm simply saying if you had to take that away, there's a lot of work to be done to win that trust then, isn't there? And do people want the data? Could you answer the other question for me? Is public health data, is citizen data of great relevance and importance to public health in the future?
Yes.
Again, I'm sorry, you have to read it to me. It's too tiny for me to read.
I will do so. I will do so, not to worry. So score 1 is the lowest, 0. Score 2, 9%. Score 3, 15%. Score 5, 31%. And the highest is score 4, 45%.
Okay, so the opposite. So really that's fascinating. So what we're seeing here is amongst your audience, there's quite a strong feeling that citizen-generated data is going to play an important role in the future. And I guess COVID has really woken us up to that, but a rather more pessimistic view about the level of trust. Well, okay, I'd better carry on with my presentation then in that case. That's really useful. And we can come back to this in discussion and bring our other panel members in. So one of my premises is that it's been too siloed. And actually, I'm not going to read all these labels on the slide. You all know these actors very well. But the message here really is we've got to work together. This is not going to be solved. This opportunity space coupled with trust is not going to happen if individual silos make their pull and run for the data. We've got to collaborate and show the public that we are working together to bring the best value from data to all. But when we ask people, and this is a study that's only a few years old, about sharing their DNA data as an example, this is a busy slide and I don't want you to do very much except look at the dark purple and the light purple shade. And as you go from me, my family, academics to pharma, you see a really growing stretch of dark and light purple. In other words, about half of the people surveyed, and it's really quite a high number. I don't have the number in my head, but it's tens of thousands of people. Oh, 28,000. Sorry, it's there on the slide. Half of the people would not share genetic information with pharma, even though pharma is using genetic information to create targeted cancer therapies. So we've got a fascinating mismatch between the opportunity and trust. How do we deal with that? I mean, for a start, why is it so difficult? Well, as we go from left to right on that diagram I showed you earlier, it is more challenging to win public trust. The public less clearly understand why and how their data are being used. The users, the organizational types that are involved, are less familiar to them. It's not your doctor, it's not your nurse, it's not your public health agency, it's big companies that are starting to use the data. The results take a long time to get back, and they may not even get back to that particular patient. The patient themselves may not be the beneficiary of the discovery. It certainly takes time before society can be convinced that allowing your data to be used as part of a population has now given rise to this wonderful result. And people feel there's less choice. So they're more anxious about how this is taking place and who's looking after their data. And I would like to propose to you that there are some principles that we should work together to uphold to achieve this. If I'm lucky, if I click, I don't see a build. Do you see build? Oh, there's a tiny screen. You are seeing the build. Okay, I'm just not seeing it on my big screen, but don't worry. What I can see here is that if you want to use data, people have to know absolutely what the purpose is. Why are you needing the data? And secondly, who are the players that are accessing the data? It should not appear as if your data, whether it's anonymous or not, is going into some uncontrolled space where people you don't know are using it for purposes you don't know. People have to be told, whether it's personally or whether it's collectively, because it's anonymized. We can't tell you how your data is used, but we can tell you, all those people living in London, we've been using your data from your GPs, the following actors are using it, and here are the purposes for which they're using it. And there must be permission. It may not be from the patient if it's not realistic, but some authority must clarify that this is a permitted use. And then on top of that, the ways in which the data are protected must be known and audited so that everybody is confident that identity has been protected. And the public have to know that. It has to be transparent. And also, it's really important that we promote the value of using that data to everybody in society. So they have to know how have benefits arisen. And we've been very fortunate as an institute in working with an activity known as Data Saves Lives, which is championed by the European Patients Forum, where we've been providing case studies. And if you just look at the blue writing, it would be difficult for you to say, oh no, the public don't really want early detection of cancer. They don't want to help fight against Alzheimer's disease. So if you get those P's right, the public can be brought on board. And I think public health, another P, has to also address how do we convince the public about this important point. And I'm going to jump the last slide in the interest of time and go to my final poll, which is actually a vote. So how important, now you've listened to me, it's almost like an exam question. How important is it to win public trust through these factors? So there are 5 factors here, and I want you to vote on the 2 you think are the most important. And we'll come back to this halfway through the panel and see if any of my panel members want to react to it as well as me. So here are 5 factors specifying a narrow range of data use purposes, promising only to use anonymized data, declaring which other agencies apart from you will be able to access the data, publishing openly how the data has been used, and providing guidance back to individuals through their apps. In other words, turning the value of using the data back to the individual person. So we're going to ask you to vote for any 2 that you think are the most influential factors to win public trust. And we're going to turn back to the panel. I'm stopping to talk. I'll stop sharing my screen. Well, I won't. If I click the button, it all goes wrong. So I won't click any buttons, but I'll ask if I can stop sharing my screen, hand back to the discussion, and maybe partway through this, we can invite the questions, the votes to be looked at. Thank you.
Thank you very much, Dipak. I would propose that we start the panel discussion now. I'll waiting for the results of the poll, then we come back to you, Dipak. But maybe we can start, Petronille, with the question that was posted for Ron, but who got the cutoff. So let's start with this, and then I think in the meantime, we will have the poll ready.
All right, thank you so much, Vicky. Yes, so there was indeed a question to Ren, which unfortunately got cut. So let us start with that. Ren, to what extent were the impressive range of studies on vaccine effectiveness and vaccine safety enabled by digital health systems?
Oh, I thank you for this question. They were fully enabled and would not have been any way possible without digital health in several aspects. The first and foremost is that these studies are data-driven. These are retrospective, mass amounts of data-driven analyses of millions of patients at a time with very careful matching of, for instance, vaccinated and unvaccinated individuals by a set of many, many different characteristics, clinical, administrative, geographic, behavioral, and others. And this kind of a very in-depth digital twin approach that would allow you to create and simulate basically a randomized controlled trial with retrospective data, what is called the target trial approach, is not feasible without a huge abundance of health data that spans years and years, and without full population coverage that allows you to justly represent the entire population. So the availability of electronic health records in Israel that span 20 years back and allow you this abundance of data, in parallel to the fact that every vaccine has been carefully digitally recorded upon its admission, as well as the fact that you have a full and immediate access to all of the COVID-19 outcomes, any admission, any test performed for COVID becoming positive or negative at the same day. All of this allowed us back in February to be able to publish this very large scale on millions of people first outcome. And this has actually what happened also later on. And the latest one a month ago with the results of the booster dose effectiveness is in the same approach and with the same data.
So we can definitely say evidence-based.
Oh, yes.
I see the question.
Digitally generated data, evidence-based.
Thank you so much, Ren. I see the questions, the poll answers are coming in, so I give the floor back to Vicky.
Good, thank you. Yes, I have them on screen now. It's also a bit far for me to read. So, question with the highest score. Thank you, that is perfect. 52%, promising to only use anonymized data. Then 46%, publishing openly how the data has been used. Third position, 43%, declaring which other agencies will be able to access the data. 35%, providing guidance back to individuals through their apps. And then the last 22%, specifying a narrow range of data use purposes. Have you got that, Dipak?
You're still muted, Dipak. Please unmute yourself first.
Sorry, I'm trying to be well behaved and mute when I'm not speaking, but I'm terrible at unmuting. Well, I could react, but I wonder if my other panel colleagues would like to react as well. I don't need to be the only one commenting on this. So why don't we give you both the chance first, if you wish.
Maybe I can give it a shot, but I think like just having a look at the poll and even having a clear communication campaign that basically you go out and reach out when you provide, for example, the health intervention. That could be a vaccination, it could be a COVID test. You make it explicitly clear there that their data will be used, they will be going to this person, and then because of this, you will receive your result by this time and that time. So even in the conversations and the relationships that we build with people, especially like the healthcare provider and the one who receives the healthcare, over there is a definitely opportunity to make it extremely clear how their data will be used and how their data will be used in a right and effective way for improved healthcare outcomes. So I think that there is an opportunity there. The conversation between the healthcare provider and the patient themselves is an opportunity to explicitly outline how the data will be used.
And if I may add something, actually, I think that's very interesting because as a researcher, when we think about promising it will only be anonymized, then you still have some bells ringing in your head saying, well, even if it is anonymized, if you have very few cases, and that was also some of the discussion in Belgium, you could still be able to identify it because it may be a rare case. So even anonymization doesn't really mean that there's no possibility at all to retrace back to the actual patient. And also the second point, which was really high, makes me think of how the data is being used. And I think when you think about different types of apps that have been used by companies, where they say how the data is being used, but then it is still used in other ways, and it leads to some scandals. the usage still remains really high. So I really wonder how we can boost that in public health, because it seems the trust is hard to win in our sector, but the trust is there in other sectors. So I think we need to be innovative as well. And maybe the benefit, like really showing the benefit, might be able to help that. I wonder, what is your thought on that?
Ren, do you want to comment on this one?
No, please go first, and I will go next.
Okay. Well, I have to confess secretly, I'm actually very, well, not secretly, I'm revealing. I'm actually very delighted by the results of the poll, because I think those, if you take the first two, one about saying wherever possible, we will work as hard as we can to protect your identity. You're quite right, Petronille, that anonymization is not a perfection. It's a relative thing, and you do the best you can. But we're also going to make clear to you why and how are we using your data. Because people are making a risk-benefit decision in their own minds when they trust or don't trust their data use. It is a risk-benefit thing. And I think early on, when I think about my own exposure to the news media about COVID-19 app development, so I'm not on the inside like the other speakers here. I'm a kind of public member, but a champion of data. Listening, it was not always clear what exactly these apps were supposed to be doing, what you're going to do with the data, how you're going to use the knowledge, what the intelligence is you're going to get. Whereas I think that if there had been a really widespread admission, this is things governments don't like doing, admitting what we don't know, saying we are desperately trying to sort out the most effective strategy we can. Here are some things we really don't know. Public, we need you to help us to learn fast how to close these knowledge gaps, because when we do, this is how we're going to use that knowledge. We're going to alter this, we're going to introduce that. That would have brought the public on board, and then say, but we understand you're scared because we want very precise geolocation data from you. We're going to know when you're going into the house of the person you're having an affair with, or whatever it is. You're going to know all your dark secrets. We're going to know when you go to a job interview with your competitor because your phone's going to be in your pocket. So we really want to promise you we're not going to use that for any other purpose than the following. And I think, and we're going to protect your identity. And, you know, as you were saying, Stefan, we're going to destroy data when it's no longer needed and so on. I think if we had taken those first two audience votes really seriously on day one, we would have stopped a lot of the anti-app anxiety that a number of countries experienced. But I'd be interested, you know, I mean, in Israel, you've enjoyed actually relatively good public support. And I wonder if you had some success stories or factors that you did take on board that maybe other countries didn't.
So I think, and if I understand correctly, the last slide was never shared because of the glitch, the technical glitch, neither did. And so funnily enough, that was actually the topic of the last slide that I presented. So I'll repeat it now. Oh. The last slide in my presentation was about the Governing Healthcare Future 2030, which is a Lancet and Financial Times commission in which we worked for the last couple of years trying to give large scope recommendations on how digital transformation is becoming a part of healthcare. And I briefly discussed the issue of digital transformation becoming health determinants, and that it is as important as a social, environmental, and other determinants of health. And the right of every person to get access to these innovations and digital tools. But the other thing that I've mentioned was that if you want to be able to do this, you really need to touch upon the issue of governance. And this fits very well with the issue that has just been mentioned right now in this poll, that says that there's two main issues. One is basically to promote architecture that it promotes trust. And the fact that you've mentioned right now, for instance, if you're keeping the patient's data private and you're maintaining privacy, and you're maintaining anonymity, and you are maintaining the cybersecurity of this data, and you're doing all of that in a way that keeps the public assured, that is very effective in creating that architecture of trust. And the other thing that's mentioned there that also fits with these answers is the issue of data solidarity. Everything you do with the data needs to come from the public, for the public, through the acceptance and the preferences of the public. And so in Israel, as I've mentioned, there's much more leniency in order to give the authority to use this anonymized data in order to promote public good, because it is used for that purposes. And for the last 10 years, we have shown the public again and again that we use it very judiciously on one hand, but in a very careful manner to make sure that the benefits that come out of it will be then returned to the public and will not become a part of the problem, but a part of the solution, of increasing equity, of increasing access, of moving towards the general goals of basically universal healthcare coverage. And so this is very helpful in allowing everyone to take part in this effort.
I see we have another question in the chat for Dipak, but I think you can all reflect on it. It's about what would be the most important lessons learned on building citizen trust and engagement in digital health that we could learn from the experiences with COVID vaccination and engaging with communities to build confidence. And then more specifically, where would you start with engaging with the public beyond informing them on data use and data purpose? Dipak, maybe you can start. It was addressed to you,
yeah,
but
I mean,
the others can chip in.
It was, but actually, I actually think in the last few minutes, we've actually been discussing exactly that. And I think what we need to do really is not expect to take out of COVID-19 beautifully made solutions. Sorry, all those people who wrote lines of code. Your lines of code are probably not the persistent value, the learning, the collaboration. My feeling is that we discovered through the COVID-19 pandemic that we are very poor at enlisting the public, and we had to work very hard to do it. We're also very poor at collaborating across countries, although the public health discipline is probably the best of all disciplines at sharing intelligence across countries. But in general, we're pretty bad at it. We don't share data much and so on. We should be prepared that the next huge crisis we hit might not be a virus. We don't know what the next one will be, but all the learning is reusable if we choose to reuse it. That's my feeling. That's what we really take out. I'd be interested in the views of the others, though.
If I may, like I see a role here, a strong role definitely of data stewardship. So there needs, and even nearly, I actually found recently I had a very good term called navigation and health literacy. Now imagine having health data literacy, or how your data is moving through an organization, understanding perfectly. So for example, in the same way that you have an application process saying your application is currently here, here, and here. Making it very clear, all right, that your data has been used for research here, here, and here. It actually reminds me of my child. When I show my child what I'm preparing for him and the food that I'm preparing for him, he shows a lot of interest and he actually eats it at the end of the day. Whereas if I just prepare it for him, do everything for him, he doesn't really engage. So there is that is something special that we really need to put forward, that we explain and we make the use so simple and understandable that, all right, then wow, I'm having a contribution here, here, and here because I decided to. So there's some value there. That's like something back, getting something back.
I definitely agree with that. And if I just may also share some thoughts that come up for me, is that indeed it's super important, and it's definitely the way forward. And then as a perspective as a researcher, it's always, I think, a challenge for us, because with the GDPR, obviously we have to respect collecting the minimum amount of information, storing the information in the minimum amount of time. But that's also really tough for research, because research come up as things change. The questions we asked about COVID at the start were completely different than the questions we're asking now. So how do we cope with that? I'd love maybe to hear some feedback from the panel. Thank you.
Well, firstly, that's a brand new panel. That's not a quick answer question. I was pleased that the poll put that scenario at the bottom of the votes, because you're absolutely right. If we want to only ever answer a single precise question, we can operate under data minimization in GDPR and just collect the few facts we need for that. But once you're going to build a data stewardship, data curation ecosystem, it's kind of nuts not to be able to answer the questions that you haven't yet realized will be needed. And that's why you need to have a different model, a model that actually doesn't govern the data collection point. It governs at use level and says, you will now need a data set for a particular purpose. We have a lot more data. We'll give you what you need, because we have a mechanism for communicating with the public. We have rules, we have bodies, we have accountability, we have transparency. That makes it possible for us to respond to unexpected opportunities to answer questions we didn't imagine were imaginable when the data was first collected. Unless we build in that capability, respecting GDPR, but wrapping GDPR in greater opportunities, we will eventually let down the ability to help our own society.
Petronille, I'm not sure if I can chip in slightly here, but I noticed one important thing. You know that in ECDC you have the EPIET training and you have UFAM training. How about European Public Health Data Science training? Now that's a training I would actually go to. That is something, and not just data science, but also in public health information systems, and getting these and building capacity across all of Europe. That is something that I think is well needed and will create a next generation of public health leaders who know these things work. Over.
Thank you for putting that forward, Stefan. And I see Ren wants to say something, so I'll give you the floor in a second. I think that's very true. And I think our skill sets has really evolved over time for public health professionals, if it's about infodemic management, digital health literacy, and so forth. So we're ever-changing profile. And I think it's important for us to train in that. And some initiatives have been initiated to work on that. And I definitely agree with you. It's very much needed in the future as well. Over to you, Ren.
So the one thing I wanted to share that basically in the last 6 years, we've been running at Clalit a unique residency program for public health physicians, in which we train them as part of their work in the most advanced parts of data science. And some of them actually go through a full PhD in data sciences in parallel. So what we get is a whole basically set of the new public health physician kind of prototype. And these are actually the physicians that have been the first authors on the New England and the Lancet and the other Nature publications that you've seen coming out. These were actually written by people who have done their residency in public health at Clalit and went through this process, including some of them have gone through all the way through postdocs in actually data science. So this is something that we thought would be the future about 10 years ago. It took us a few years to create this program, first of its kind. And now we have the second and third generation of these people are actually mentoring the new public health physicians that are now in residency. So it's a kind of, I think it's an interesting thing to look at.
I see Karen back on screen, which means that the end of our session is approaching. But Stefan, I would like to thank you for being an ambassador of the fellowship program. We are reviewing the curriculum as we speak, so it's good that your thinking is in the same line as our thinking. So we can exchange ideas on how to improve and reform in the future. So I think if I can summarize, I mean, we started with the question, digital public health, how far are we from reality? I think we replied to that question in this session. It's already here, and it seems it is here to stay. We had some nice examples of success stories and applications for real-time surveillance, response, monitoring. We also listened to some drawbacks and challenges, such as the low uptake of contact tracing apps. But leaves me and Petronille to thank the audience and to thank all of the speakers. We know that you're all very busy for being here today and for sharing your views on how digitalization could shape public health for the future. So thank you very much to all of you, and thanks to the audience. And right in time, I give the floor back to you, Karen.